All right, so let's play some modifieds here, and I'm going to try to offer some additional commentary to the narrator here to sort of put things into the language and the level that we are in the class.
This 56-year-old man had a 1-year history of terminal bulbar onset motor neuron disease. He presents with a moderate spastic dysarthria and has very little functional movement of his tongue due to upper motor neuron involvement. As his swallow is deteriorating, he reports coughing on saliva and is beginning to lose weight.
All right, so very little movement of the tongue, which we're going to see negatively impacts his oral stages.
He agreed to hospital admission for PEG tube insertion, while his respiratory status remains adequate.
A PEG tube is a feeding tube.
A video fluoroscopy is completed once the tube has been inserted to determine if there is any food or drink consistency he can continue to take in small amounts for quality of life purposes. This clip demonstrates that this gentleman has a significant oral stage dysphagia. Once material is placed in the oral cavity, we can see that it remains in the anterior sulcus. He's unable to collect the material with his tongue in order to form a bolus and propel it posteriorly to initiate a pharyngeal swallow.
So he's struggling with bolus formation. He's struggling with AP transit.
Note that he uses a head-back compensatory posture to try to move the material posteriorly. Anterior spillage of material is also evident due to weak lip seal.
Anterior spillage is the bolus coming out from the lips. Posterior spillage is it falling back into the larynx.
When a very small percentage of the bolus reaches the pharynx, we can see that the pharyngeal swallow is delayed and effortful, and only a minimal amount of material enters the esophagus.
So let's go back and see that delay.
To move the material posteriorly. Anterior spillage of material is also evident.
So we would already be counting
when a very small percentage of the bolus reaches the pharynx,
4, 5. It's about a 5-second delay.
Only a minimal amount of material enters the esophagus.
Pharyngeal
Upon completion of this
stasis.
examination, this gentleman decided he would no longer take any food or drinks orally.
A little bit of pharyngeal stasis in the vallecula and the piriforms. He seems to have cleared that.
As he found eating too exhausting. This 35-year-old woman has a 5-year history of the degenerative condition myasthenia gravis. She presents with moderate flaccid dysarthria and mild swallowing difficulties, which are more pronounced once fatigued towards the end of meals. She compensates by eating small amounts often, avoiding chewy solid foods, and by taking medication half an hour before meals to optimize swallowing. Note the following. During swallowing, the tongue base does not retract to meet the posterior pharyngeal wall in order to propel the bolus through the pharynx and through the upper esophageal sphincter.
So a lack of pharyngeal constriction, and this is a great example of a pretty severe lack of pharyngeal constriction. So myasthenia gravis, the whole body is flaccid. So all the structures involved here are weak and flaccid.
The soft palate does not elevate to block off the nasal cavity, and the epiglottis does not tilt to meet the arytenoid cartilages and protect the airway. Markedly reduced hyolaryngeal excursion during the swallow results in reduced airway protection and moderate residue in the piriform sinuses.
So you see during the swallow that in addition to the pharynx not squeezing, the epiglottis doesn't come down, the larynx doesn't come up, the airway basically just stays wide open. I'm going to back up a little bit so you can see that again.
Soft palate does not elevate to block off the nasal cavity, and the epiglottis does not tilt to meet the arytenoid cartilages and protect the airway. markedly reduced hyolaryngeal excursion during the swallow results in reduced airway protection and moderate residue in the piriform sinuses post-swallow. And the individual is at risk of aspiration post-swallow when she resumes breathing. Post-swallow residue on the tongue base and in the valleculae across all consistencies is noted.
All right, so you can see that the bolus stretches from her oral cavity down into the esophagus without really any break. The pharyngeal swallow we know it's happening because there's a slight squeeze, but like I said, there's nothing is squeezing in tight. The airway is being left wide open
due to a weak pharyngeal peristaltic motion.
She's not getting much into the UES.
Swallows are elicited to clear the pharyngeal residue, although it must be noted that she reports she does not sense any residue in the pharynx when asked. Despite poor airway protection and marked post-swallow residue in the piriform sinuses, there is no evidence of airway penetration or aspiration.
So no aspiration or penetration. If you saw that in a modified Bierman swallow, though, you're going to be very concerned about the possibility of aspiration and penetration. So you're probably going to test her on thin liquids very well to be sure you have a lot of data and she's not showing any aspiration and penetration. You're going to interview her very well to make sure she's not reporting any signs or symptoms of aspiration or penetration.
This 62-year-old lady was admitted into hospital with significant dysphagia of unknown origin. She was referred by the neurology team to the speech-language pathologist and was placed nil by mouth, also referred to as nothing by mouth based on a clinical bedside assessment.
Also referred to as being NPO.
Nasogastric tube was inserted to address her nutrition and hydration requirements, while work to form a diagnosis was conducted. She was referred for a video fluoroscopy to establish the nature of her dysphagia. The following was observed. Only a small percentage of the bolus was actually passing through the UES into the esophagus during the swallow. We can see that this is despite some hyolaryngeal excursion and contact between the tongue base and the posterior pharyngeal wall during swallowing.
All right, this is a messy looking image, but here's the mandible. So here's the chin right there. So this is the ramus of the mandible back here. Here's the angle. So this is the base of the tongue right there.
Note that there is significant residue in the piriform sinuses post-swallow.
So vallecula, piriforms right there.
Secondary to impaired opening of the UES during the swallow. To a lesser extent, some residue remains in the valleculae post-swallow.
So some pharyngeal stasis.
Anterior-posterior viewing demonstrates bilateral residue in the piriform sinuses, and a head-turn compensatory posture was then attempted in an effort to improve bolus clearance from the piriforms through the UES. But we can see from the residue that it was of limited benefit. This presentation of impaired UES opening on video fluoroscopy was in keeping with this lady's subsequent diagnosis of inclusion body myositis. After corticosteroid treatment, her swallow improved to a functional level, and she could meet her nutritional needs orally.
So they tried a head turn to help compensate, to help improve the swallow, and as you can see here, you still have a lot of stasis, so that didn't really work to reduce stasis.
A 68-year-old man in good health presents with a sudden onset of dysphagia. He reports not being able to initiate a swallow and difficulty swallowing his secretions. Clinically, his voice is wet dysphonic. On test swallows, there is considerable labor in initiating a swallow.
All right, so what we're looking at here.
Movement on laryngeal palpation. A video fluoroscopic assessment of swallowing is performed.
So assuming this guy is intentionally moving the liquid bolus into his pharynx, which it's sort of I think we can assume he is. He's getting pooling in the vallecula, pooling in the piriforms, and usually when you're getting pooling, it means that the bolus is getting into your pharynx and there's no pharyngeal swallow that has been triggered. So it looks like a delay. There's sort of a slight squeeze there at the beginning. Either he has an absent pharyngeal swallow or an extremely weak pharyngeal swallow.
The pharyngeal swallow is observed to be severely weakened or absent through much of the examination.
All right, that's what I just
said. At the onset of the study, a single thin liquid bolus is presented via a cup.
All right, I'm going to mute this guy for a second. All right, so we've got pooling. We've got a delayed pharyngeal swallow. And what he's going to get to here in a minute is you're going to see some aspiration, but the aspiration is not going to come down from the vallecula along the anterior airway, wall of the airway, which is what we've seen so far. This aspiration is going to spill over the aryepiglottic fold from the piriforms, and it's going to roll down the back of the posterior wall of the airway right there. And the esophagus, the UES is about right here, so the esophagus is back here. All right, so you see the UES. This is sort of pointing at the UES right here, that little piece of barium. And there you see some aspiration. There's even more going down the back wall of the airway. Now we've got some penetration sitting on top of the vocal folds. And you also did see little pieces of the barium getting into the UES, moving past the UES into the esophagus. It's a very weak pharyngeal constriction. Let's go back, see if I can get this to play again. All right, so 1, 2, 3, 4, 5. He's either got a very long delay or that squeeze is his pharyngeal swallow, and it's not doing much of anything. There's the aspiration. So what are we seeing in this guy? A long delay or an absent pharyngeal swallow, or there's a very weak pharyngeal swallow and we're just really not able to see it when it happens because there's just not much visually to show us that is the pharyngeal squeeze. We had pooling before the pharyngeal swallow, and if the pharyngeal swallow is happening, which something seems to be happening because he's getting bits and pieces down into the esophagus, then we would then call this stasis, and that's just a lot of residue because as you can see, there's just not much happening pharyngally. And on top of that, you have the barium piling up in the piriforms until it is spilling into the airway and coursing down the posterior pharyngeal wall. It's a little bit of penetration right there. There's aspiration. There's a little bit going down the esophagus. See what our narrator has to say.
Laryngeal elevation, and no material is seen to pass through the upper esophageal sphincter. The liquid is pooled in the piriforms and falls into the laryngeal vestibule and along the posterior tracheal wall on 2 occasions without spontaneous airway clearance, resulting in a penetration aspiration scale scoring of 8, defined as material enters the airway, passes below the vocal folds, and no effort is made to eject.
So he didn't cough with that aspiration, so that would be a silent aspiration.
A trace amount of liquid is noted to pass through the UES during a subsequent swallow attempt. Following a few weeks of therapy, the patient begins to demonstrate improved management of oropharyngeal secretions and begins to take food and liquid therapeutically. As he appears ready to support nutrition and hydration through oral intake, a video fluoroscopy of swallowing is performed to monitor progress and to rule out silent aspiration. The initial small presentations of thin liquid show advancement of the bolus to the piriforms with a more immediate initiation of the swallow and less struggle behavior.
All right, so way better looking. A lot went down into the esophagus, but it still looked like there may not have been a very strong squeeze.
Once initiated, velar elevation is complete. Higher laryngeal elevation and tongue-based retraction are improved.
Yeah, I take that back. So when we go back, I'll try to go back and watch. You're going to see that the anterior pharyngeal wall, which is the base of the tongue, is going to contact the posterior pharyngeal wall.
8. Higher laryngeal elevation and tongue-based retraction are improved. While pharyngeal contractions are also improved, there continues to be reduction in the amplitude of bolus propulsion in the mid-pharynx, with mid-pharyngeal and distal pharyngeal retention noted during puree swallows.
Okay, here I got it queued back up. So we're looking at the increased pharyngeal constriction. So you're going to see the posterior. So the tongue-based, that this area right here is going to close and squeeze a good bit. Functionally.
Continues to be reduction in the amplitude of bolus propulsion in the mid-pharynx.
But still, as he's saying, still there's some struggle with bolus propulsion in the mid-pharynx, which means that pharyngeal constriction, it's a lot better, but it's not great, not super.
With mid-pharyngeal and distal pharyngeal retention noted during puree swallows.
So he has some stasis on the purees.
There are no events of aspiration. The patient appears capable of initiating oral intake to support nutrition and hydration.
All right, and let's go ahead and review the normal swallow. And this is the normal elderly swallow. So the pharyngeal swallow is going to be cued a little bit later, meaning the bolus is probably going to get down to the level of the vallecula. A bolus is going to be held more posteriorly. During the oral phase.
This is a video fluoroscopic swallow examination of an 84-year-old woman with a history of ischemic heart disease. She was referred for an instrumental swallowing examination because she complained of food occasionally getting stuck in her throat. At the time of the video fluoroscopy, she was on a regular diet. The first few frames of the examination show that the patient has poor dentition, and as a consequence, chewing is likely to be impaired. This always needs to be borne in mind when considering which consistencies to trial during the investigation. When the patient trialed thin,
you can see that thin liquids are moving quickly through the pharynx. There's no signs of aspiration or penetration. There's a little bit of pharyngeal stasis, but that's within the realm of normal.
In liquids, we can see that there is reduced laryngeal elevation and incomplete airway closure on this swallow. On this thin liquid swallow, there is delayed pharyngeal swallow initiation with premature spillage. A small amount of residue in the folliculae can...
Premature spillage, that's another term for posterior spillage. And so he's saying all those things about that person as compared to a younger individual, but everything that he noted there was functional and for a person this age within the realm of normal.
Be seen here with some coating of the posterior pharyngeal wall. This residue and coating is within normal limits expected, given chronological age.
So you saw right there that was some pooling, about a half-second delay, but then functional swallow, quick, and everything was cleared appropriately.
When the investigation moves on to trials of puree consistency, we see an example of a delayed oral bolus transit. This delay does not indicate a disordered swallow. It's a reflection of the
delayed oral transit. He's referring to delayed AP transit.
Normal slowing down of oral transit with age. Next, we move on to show an example of delayed oral stage on a swallow of soft food. Here you can observe mild oral residue after the swallow, which is not considered pathological in a patient of this age. When the patient is moved into anterior-posterior positioning, screening of the esophageal stage of swallowing is facilitated. This is not always considered a norm in video fluoroscopy.
So here's something we haven't really talked about, but during a swallow, the bolus, liquid bolus, is going to come off the back of the tongue, and it's going to pass around the epiglottis, around the airway, so it sort of tends to divide up into two streams. And then it comes back together at the UES and then passes into the esophagus as like a single thing. So when you're watching the coronal view and you see what seems to be the liquid bolus splitting and then sort of coming back together, that's exactly what's happening. That bolus is flowing around the epiglottis, around the airway.
But can prove useful for differential diagnosis. In this position, residue is observed in the lower esophagus, with some degree of delayed bolus transit being evident. While still in the AP viewing plane, an example of delayed oral stage transit with a soft consistency is demonstrated. This is followed by intraesophageal stasis with mild retrograde bolus flow, or reflux, at the top of the video fluoroscopic image. This video shows an elderly swallow, which cannot be considered as disordered, but at the same time cannot be considered as standard for all patients of a similar age, or even older. What must be remembered is that huge variations in the normal elderly swallow occur, and what has just been shown is just one example.